Okay, thanks for the introduction. Thank you, Directorate of Public Health, for arranging this particular conference. It seems my slide templates have got really changed. I don't know whether the same it works or not. This particular topic, which is creating a lot of noise in this our recent past 5-7 years in our Tamil Nadu public health system. As usual, Tamil Nadu public health system being a pioneer in terms of introducing lot of innovations, be it is in NCD care, be it is introducing some of the earliest community-based screening for cancers, hypertension and diabetes. Tamil Nadu also has a tremendous experience of trying out lot of digital health solutions at different facilities and as well as in the field. But apparently, what actually we need to really look into that is that whether those solutions have been used. Our primordial duty is that in delivery of public health program service delivery, whether those health solutions have been useful for that or not. So in that particular line, I am going to discuss with you all, with your day-to-day experience of using multiple digital health tools at different occasions, be it is an immunization program, be it is an NCD program, or it is an maternal child health program. There are multiple digital health solutions that you have tried upon. Many of you could even list out very clearly. We did one exercise along with one of your officer. You maybe get surprised that Tamil Nadu government has tried nearly some 40 plus digital health interventions for various different programs in the field. Despite there were multiple starting points, interruptions, some were getting continued and everything is there. But what I am trying to bring here and discuss here is that I wanted to touch upon some of the basic fundamentals on whether these digital health solutions are really helpful to support us to take decisions in service program delivery, public health program delivery or not. There are two different important providers. One is the medical officer or the staff nurse or the VHN who is at the ground level, directly providing the health care at the facility at the primary care level. The second is the program manager who is taking larger decisions in allocating resources to some of the health facilities, reallocation and reappropriation of that. For both of them, they are using the digital health solution. Different parts of it. I can name few, whether there is an MTM linelist.com, your PickMe, or for say like the recently introduced, when there were COVID, we used CoWIN, or we could say like in our IDSP, we use IHIP. There are multiple different platforms for various different purposes. Some are vertical into that. So let me just walk through that and with the basic fundamental, what we usually think digital health. There is a digital health and interoperability work group formed in 2019. This is a newer terminology, but it is brought down from the older terminology called telehealth, e-health. Then we have under this called digital health. If you see that digital health is a long definition, but I wanted you to focus on certain things, which is this. I don't know why this is gone. Fine. It's a systematic approach on two things. IT, data, mainly for what? Informed decision making. Why informed decision making? To strengthen the resilience, which means to strengthen the resilience of the health system to handle diseases, and also what the intended wisdom is to improve the health and wellness. When I just put it across and highlight these specific parts of the definition, then you may now think that what actually is going back and is that box is pertaining to the data. Data should be linked to the decision making. Let's do some practically. You are collecting the patient data from the field who are all suspected hypertension. Imagine that. And why we are collecting this data? This question we need to ask. I'm putting a data about, okay, these are all suspected hypertension, these are all suspected diabetes. But the intended decision making is that whether these people have reached to the next health center or not. What the major basic digital health principle is saying is that if you are that information you are not getting, then there is no purpose of it. What happens in the back end is data being generated into meaningful form of information, and that is converted into decision. This is the linkage which happens in the back end. But furthermore, the decision has to do some action. There are multiple dynamics in all these steps. That's why the real digital principle is trying to bring focus on all these individual steps, not doing any kind of shortcuts. Before you decide what data to be collected, you need to think what action to be taken. If you are not clear with that, then whatever we are collecting the data will not be useful. That's all the bottom line what the digital health is trying to say. You very well, every one of you know that these are the 6 pillars of the health system. This is the basic WHO framework. If you want to run a health program, all these 6 pillars are essential. If you see that one of the important pillar and a determinant of health is information system. The information system actually helps all other pillars to improve your service delivery. The information system helps you in order to estimate your medical products, vaccines, drugs. Your information has to help to manage your funds. Your information has to manage your health workforce, and your information system has to help the leadership in order to take decisions critically. This may be simply seen as the kind of 6 pillars, but fundamentally more amount of, then you see that if that pillar is going to strengthen the rest of the 5 pillars, then how robust and how practical that pillar has to work out. You may simplify with these following steps, 4 key functions: data generation, compilation, analysis, and then communication and use of the data. But please don't oversimplify what is mentioned there. There are 3 important areas where we are having a huge difficulty. Definitely, I won't agree if someone says that we have a difficulty in generating the data. We are generating a lot of data. The major difficulty starts from that is converting the data into a meaningful form of information. The second major important difficulty here is that information has to be communicated to those who are going to take action. If you think that the information has to be communicated to the health secretary or the directorate, you are completely wrong. The person who is deciding the fate of your public health program is the ground level person. Are you communicating that particular information to the ground level people in order to take their decisions? For example, you are trying to tell that a VHN, you can see that your coverage of vaccination has gone down. There are a lot of outbreaks of measles has come up. These are all the pockets inside your place, inside your service area which have been affected. That is the level of communication. The third important problem is that use of that data. This is another thing. Data use is the biggest thing, which means what? Even though I provided information, I don't want to use it. As I said, there are 40 plus digital health applications in Tamil Nadu. Everyone will be having every dashboard. How many of us actually taking decisions using the dashboard? Simple. We need to ask critically that. If that is not there, the whole generation of the data information is not going to be useful at all. It is going to be again a painful exercise. I'll just give one example about hypertension. Assume that a state with an adult population of 5 crore. Okay. And assume that 25% is the prevalence, very nominal prevalence as a nation's average. So there will be 1.2 crore hypertension patients will be there in a state of 5 crore adults. Assume that 50% have been identified and they are aware that they are having hypertension. So 60 lakh hypertension patients. Please understand, this includes both government and private. Assume that 50% are only under care in public sector, which comes around 30 lakh patients. Assume that the patient is visiting at least 6 times a year, either to the health facility or encounter with an healthcare worker in the ground. 6 times in a year. And assume that you are going to collect only 3 information, not much of data, 3 data points. Their date of visit and their blood pressure value and the medication what you have provided. These are the only 3 information. You would have seen all your MTM notebooks. This is the only information that we are reading. Date, drugs given, BP reading. True or not? This is what we are writing in the notebook. Take a vaccination, this is also will be writing. What is the date of vaccination? What I am trying to say here is that you will be having 6 crore data points per year, even with this nominal numbers with only 3 data points. Now, most important difficulty here is that this is a chronic disease. It goes on over a period of time, which means throughout the lifetime. So, in 10 years, it will generate 60 crore data points. In 20 years, it will generate 120 crore data points. Now, how are you going to manage this data? Of course, everyone will disagree. It is not going to be pen and paper. Definitely, all this data is going to be useful for you to really tell that I invested this much amount of crores for hypertension control program. How much actually I have taken out? Then definitely you need all this data. You cannot say that this data is a waste data or dumb data. I am going to only record it in a pen and paper. No, definitely not. So you need a digital system. This is the bottom line. But fundamentally, that's not a simple one-line answer. What kind of digital system could provide you in order to take such certain decision? I'm just moving ahead. If you see that a basic information required for a hypertension control program, when you are investing huge number of money, when you are sending huge workforce in the ground, and even as a program manager spending lot of time, your personal time, your professional time, with all this burden and burnout, then we need to take whether this data being generated is used as an information or not. Can you just see that I'm just putting across how the program works. The basic information which you require to run an hypertension program at the input level is drug stock, blood pressure machines, HR. These are just the 3 basic data for input. Whereas in terms of process, you will try to, at least the basic information is required. Okay, I spent some 50 crores in a particular state, and in the 50 crores, I have deployed some 1,000 workforce in the field, and I have also took pain to bring a treatment protocol. Now, definitely one important answer, we want to improve quality. We are a well-developed state. We need to focus on quality. How much have been treated as per the protocol, a basic quality parameter for a hypertension control program. That information we need to generate for a state like Tamil Nadu. And that, second, there may be some people who requires a referral, and that also we need to know how many I have referred, how many have reached out. At the end of the day, you are reducing cardiovascular disease deaths. That's your intention of your hypertension control program. The third level of minimal information is output, which means this much number of patients I have registered. Dr. Krishnaraj sir has told that nearly 1 crore beneficiaries that we have been treating. Assume that there are some 40-50 lakh hypertension patients. Of those 40-50 lakh hypertension patients to which we have provided the drugs, how many of them have come for regular follow-up? Do we have that information? Simple question we need to ask. And the further, if you do have all these things and do a quality, I totally agree, public health service delivery is a different ball game. It cannot succeed the idealistic level. Challenges, dynamics plays a role. But this, we need to have an expectation and benchmark of it in order to get this one important information. Whatever you do for hypertension, you give drugs, you teach yoga, you do health work, whatever you do that, fundamentally you need to achieve one particular indicator, which is the control. Do we have that information? Please remember, this is a dynamic indicator. This will change once in 3 months because it's a cohort. We need to continuously monitor. Whenever there is a continuous monitoring, there is a huge amount of discipline, rigor in information system is required. That's why surveillance is very difficult to implement, because it's a continuous monitoring of disease. Hypertension, diabetes is not at all away from that. Please understand, when population increases, burden is there, your more number of beneficiaries is there, you are going to handle many people. We can simply do away with that. This is what we could do. But at the end of the day, we have to answer, I spent 100 crores, what I have achieved it. Fundamentally. We cannot simply play with the numerator number, this much number of patients I have enrolled. No. Again saying, we are not that particular level of, I enrolled this much number of patients. What happened to them? Did we really save their lives and treatment outcomes? Okay. Currently, there are multiple softwares, apps, everything. But at the end of the day, if you go to a health facility or a health worker, they're super dependable where they are having a good control. Please understand. They are having a capacity to handle it, which is nothing but pen and paper registers. And registers have been being maintained. It is irrespective of whatever the state, registers is their really life-saving. And they depend on that. And when you know the previous problem, when you depend on register over a period of time, you cannot generate the sufficient information. Now, this is what the bottom line for a single thing which I am trying to say. Then you sum up in terms of diabetes, in terms of cervical cancer or whatever it is. So what actually a good information system do, which is related to a program implementation? 4 things. I need to have a better indicators for planning. I need to be informed by the information system on these indicators for planning. I need to have a better day-to-day decision making. When the program is being implemented, it will go here and there. I need to be informed by the better control and oversight whether my health system is actually delivering what it is intended to do that, despite whatever the noise, whether it is minimal level. And finally, reduce the administrative burden. I give a simple example. Every one of you have been using GPay or any other, most of you must be using it. Most of you having a banking software. And these, you have all these things. If you go and check that, you have this. And why we are started adopting it? Because I have a control over it. I have a better oversight. I know where to stop. I know where to control that. We need to learn from our previous other examples for that. Forget about digital. I will tell one best information system which is used in any healthcare system. The best program which is being implemented by any health system, immunization. In immunization, which is the information system? Immunization card. That is the best information system. A card with an ANM, a card with the mother. Even though the beneficiary is going out, the card carried will tell that whether the patient is given that particular vaccination. But fundamentally, over a period of time, when your numbers swell up, when the migration happens here and there, that card won't work. And we need to come up with some other information system. That's all the most important game we need to understand. Now think about hypertension and diabetes. You have nearly some 1.6 crore hypertension patients in Tamil Nadu, which is estimated. I'll give one simple why they want to better indicators for planning. One example, I want to know that which facility has more dropout of patients. This is one program manager want to know. Or as a medical officer sitting in a primary health center, I have XX number of hypertension patients. Of them, how many are not coming under care for more than 3 months? If I don't have that basic information, then you are losing a planning view. That information is important for your planning. Then you can't plan well. We need to accept it. And which facility block has poor control? You need to know that as a district level program manager. How you have to evaluate whether the information is providing that this particular decision to take is that like, are we generating these indicators? Critically ask ourselves. Whether this information is used by the program manager. Data use. It's not data generation, information and communication. It's data use. I should see the dashboard. IHIP has a dashboard to tell about the reporting status of the reporting units. This is everywhere. But are we seeing the dashboard? There are multiple reasons. There is no mandate. There are multiple reasons. We don't want to see the dashboard seems ugly, or I don't like the platform. There are multiple reasons. Or that information is not useful to me. But we need to critically look into this before we talk about, I need a good information system. Second, better day-to-day decision making. Example is, which facility reported stock out of drugs? This is a commonest problem across any health system. Suddenly you will have huge number of beneficiaries. Based on previous year consumption method, definitely you cannot estimate the drugs. The same goes for vaccines also. Like, we have a calculator for vaccines in terms of adding that particular part. But how we evaluate the success? Similarly, are we generating these indicators? Whether these indicators information is for the program manager, over a period of time, are we improving the outcome? There is a literature which strongly supports nearly 90% of the health IT fails. This is not India, across globe. Health is the last sector which can adopt technology. And in health, most of the time it fails. We have our own experience to tell that. It may not survive even more than 2 or 3 years sometimes. What are the reasons? Literature supports these points. These are all jolted down very well in this document. Planning an Information System Project, a toolkit for public health managers, jointly released by WHO, PATH and USAID. Very simple document, 30-page document, clearly given steps. They highlighted based on the literature, these are all the major problems. Number one, we want to go by shortcuts. I totally aware that the decision of the information system is not taken usually in ideal manner. It's all taken with a different dynamics. Okay. When we go with the dynamics, with the shortcuts, definitely you will not have enough time on system analysis and design. Definitely. So it will not sustain. It will fail. It will be poorly adopted. They won't like it. I'll give a very simple example. Skype Messenger was there before WhatsApp, Facebook came to existence. Skype has all the features, whatever you have in WhatsApp, in the some 7-8 years before itself. Skype had a texting, Skype had video calling, Skype have even groups. But why Skype failed? You forget about all our information system. Think about how huge amount of investment has happened. Skype was very successful over a period of time. Facebook Messenger came. It had all other features which Skype could not have. Document sharing, many things and all. It also failed. But why WhatsApp succeeded? We need to think. WhatsApp started very simple, small steps. Well designed, well thought, no shortcut. That's why it is surviving now. Even though if they want to close the WhatsApp, huge movement to say that please don't close the WhatsApp. It's all design thinking behind, taking time, no shortcuts. And second, we need to consider the end user. Who is the end user for any of your portal? Maybe the field level healthcare worker, the staff nurse or the medical officer. Are they being involved in designing the information system? Majority of time, definitely no. They were not at all involved. It's all top-down approach. Morning, Dr. Shantaraman told, Dr. Sundaraman said very well, na doctor, ni doctor. That's a kind of an attitude approach. Top-down. I decide, you use. That won't work. You know very well that's why we are failing. Third, unsuitable technology for the scale and usage. You cannot assure a very good internet everywhere. I can definitely say even in Chennai there are multiple dark spots. Even you cannot get G or E, which is the 1G, 2G. Forget about 5G. When you have that, when you develop an information system which is at the field level usage and that has to depend on internet means, then that is not going to work out. Which means that, okay, right, fine. Whoever has internet, let them usage. That is a kind of attitude we are pushing it. Unsuitable technology. Second, it may be mobile, it may be a web-based platform. Now recently there is a major problem that I am observing in the public health, digital health, IT is that they design a portal and push it for mobile usage. Which means they don't understand the healthcare worker is going to use a laptop or a computer or a mobile phone. So that is not understanding the ground level technology usage. Poorly planned budget or rigid budget. There is a method in digital health or IT which is called waterfall method. What is waterfall method means? I decide the requirement, everything at the beginning itself, and I just close it. This is what you are going to develop to the vendor. Please understand that in IT, it is software as a service. It is an iterative process. You take WhatsApp, you take GPay, you take Instagram. Do you believe Instagram have 10,000 employees and there are 2,000 behavioral scientists? That much number of people are behind that simple Instagram. Even WhatsApp has a huge number of people. Continuously we have to work on that. If you have a waterfall method, it won't work. Sprint method, you need to do that. And pilot systems are not evaluated honestly. We need to be very clear. We develop a pilot, agreed, but evaluate it in the field, take honest opinions and then scale it up. What we do is, I completed pilot and the next day I am going to scale it up. Who is going to suffer? The poor healthcare worker who is at the ground. And second, you have huge dump of data and we don't know what to do with that. And we will criticize the quality of it. We themselves criticize. Oh, that data may not be right. So this is why many digital health system fails. So basically the purpose lost and the poorly used system, context lost and will not sustain and will not scale. This is the fundamental thing that we need to understand. Finally, I just want to tell that, this is my last slide. This particular document which I have shown, they jolted 8 simple steps for developing a good digital information system. I just walk through it randomly. Defining outcome means very simple. You need to know what your information system should generate for action. Very simple. You want to know control rate, you want to know dropouts, you want to know vaccine wastage, you want to know where is the clustering of cases. Define that outcome prior. Don't put a table that I need these 10 data points, then I will decide what outcome. It is a wrong approach. First, decide your outcome first. Second, you need to have a good team. The good team means what? Of course, now currently post-COVID, everyone is an epidemiologist, everyone is a public health person, and everyone is a digital health expert also. Because it has democratized that view that I can comment anything. So that is not the team. The team is multidisciplinary. We need to respect. We need to have a digital person. We need to have infrastructure person. Doesn't mean that I have used a digital health system for 20 years. If I used WhatsApp for 20 years, can I say I am the expert of WhatsApp? Definitely not. But that attitude we need to. We need to have a good team which consists of all these people. Define what this system needs to do. Basically, you need to keep your data points very, very, very simple and lowest for taking actions. Having 20 variables is not going to be useful at all. Find the right solution. There may be open source, there may be vendor based, there are multiple things. I don't want to detail here, but that particular document details how you have to take the right solution for that, which means choosing the right product, right technology. Select the right vendor. This is another biggest thing. This document clearly explains how you need to be careful in selecting the vendor, otherwise you will be in soup, administratively, technically, politically, lot of things will be there. At one point of time that we will be seen as a jokers. We public health professionals actually having the intention to improve the health and wellness of the people. But when you are doing in this game, without knowing you will be seen as a joker, things will be going around it. We need to put our foot very, very strong. Make sure only when you do this, then only I will adopt a digital health information system, which is not happening per se. Sixth is estimate implementation and operational cost very practically. You need to think about not only pilot, think about the increase in number of patients, your scale, increase in number of users. Then you need to think about your infrastructure, server, mobile phones, data, all these things we need to have. And create an implementation plan and finally understand and manage the risk. This is the last thing which we usually definitely never think. We have an attitude of optimistic behavior. We can do everything well. Please don't have it. We need to be acceptable for vulnerability. We will definitely fail. Only when we have that attitude, then only we'll think about the risk, then only we'll succeed minimal level and over a period of time to achieve the expected level. When you have an attitude that I can deliver anything, we will be in definitely a big soup. We should not be part of a humongous decadal failure. We need to be very careful in that. I'm telling about that. So what actually the digital health 6 principle says is that small is big. Knowing is not enough. I know WhatsApp. That doesn't mean that I know every technology of WhatsApp. It's called Duncan-Kruger syndrome. Third is intentions are not actions. I have a good intention, but that does not reflect in terms of action. It has all other things to do that. Truth is always buried. We need to dig truth. Devil is in details. Put the truth on the table honestly, brutally, accept it on the table. Context comes first, not the technology. Attention is elsewhere. So this is what we need to clearly in mind. I didn't want to tell about the technology part of it, capacity part of it. India is an IT hub. We have a great capacity. It doesn't mean that we developed a WhatsApp. All those WhatsApp, Twitter, or the Facebook developed people, maybe Indians may be sitting there. Which means collectively there is an organizational capacity which we are lagging. We cannot be able to bring them together. Today I was talking briefly with Dr. Sunil Nandaraj. He clearly mentioned that the healthcare system is more individualistic in Indian healthcare system. It is not group behavior. We as an Indians have a problem of bringing and working on a team. Actually, we need to work on us. When I say we, it includes every other professional who is working for health and wellness of the people. I want to be very, very honest. It's not blame game. It is accepting the truth what is there in the ground. Thank you very much.
Thank you for the pearls of your wisdom, sir. Now the podium is open for any questions. We kindly request Joint Director of Public Health and Preventive Medicine, HEB, Dr. Shanmugasundram sir, to honor the speaker.